All right, good evening. We have officially not yet started our chat show, but since we were 6 minutes earlier, we thought why not actually catch up with all you lovely people who are just waiting to meet Dr. Vijay Kher live on Facebook. So, for those of you who want to say something, send in your messages on the Facebook live chat, and we can, of course, welcome Dr. Vijay. Dr. Vijay, before we start, do you want to share informally a few words to our community?
Yeah, I'm very glad. I welcome everybody who is there, and I'm very glad to get associated with the Kidney Warriors again. I had a session with them in New Delhi about a year back, year and a half back. Vasundhara was there, and it was very good to organize a, an event, a live event with a lot of patients who talked about their experiences and all that. It's always good to hear patient experiences. As a physician, it is what we give them as a good advice, what they should do, what they should not do. But patients' experiences are the best experiences for other people, especially. And so it would be very, very important that today I would want to have questions from people who would want to ask anything about transplant or kidney disease. I would be very, very happy to answer any of those questions, and it would be a pleasure to do this show.
Thank you, Doc, so much, Doctor, because I think you set the forum for people to just be so open and ask you any questions. So I'm sure people from the community are really excited as much as we are to connect with you. And I mean, for the kind of experience that you come with, there's so much of knowledge. I can just call you the encyclopedia as of now for us.
That, yeah, I have been around for a long period of time. About 45 years of medical experience.
Wow.
And transplant and kidney, 5,000 kidney transplants.
Wow.
So been around for about 35 years in nephrology. So that's a obviously many years that you have. Many of you wouldn't have been born then, probably.
I just came into the world, I think so.
Yeah, that's what I said, that many of you wouldn't have been born. So that does. So experience does add some different kind of value, but I agree that ultimately it's the changes which have occurred in these 35 years, and it's been such a good to be part of this extremely rewarding changes that have happened in transplant field and nephrology as a whole. And we are looking forward for much greater changes that will probably change the way people are going to be treated with kidney disease. I am very hopeful. I hope it happens while I am alive, but I'm sure it would definitely happen.
Sure it will. We're all staying positive for the same. In fact,
yes.
Just last week we had Dr. Sundar with us, and he spoke how the transplant industry has evolved.
Yes.
And he started his journey, and it was so amazing just to hear the things that he had to say. And I think we've come a good way actually in the last years that Dr. Sundar was putting across to us.
Yes.
There's a brighter future for patients to come, for those of them who could be affected by CKD, but I'm sure there's a lot of opportunities that we're all waiting for as a community.
Yes. There is also a lot of excitement in the newer drug development which has happened, and recently newer drugs have evolved which are going to slow down the rate of deterioration of kidney disease. So if you have somebody with early kidney disease, it's very likely that we are going to delay the need for dialysis or transplantation. That is going to be a game changer, and I hope that happens.
How long are we talking about these drugs coming out, Doc?
No, these drugs are already available now. These are drugs which have been used for diabetes, SGLT2 inhibitors, and dapagliflozin and canagliflozin, and these are drugs which are available now for about 3-4 years, used for heart disease, heart failure, as well as now for preventing progression of kidney disease. So very, very exciting area which is developing, and I'm sure that's going to be very good.
Thank you for starting off this show on a very, very happy note and getting us all excited. Doc, I think we are good to go officially.
Okay.
So formally, once again, Good evening, ladies and gentlemen, boys and girls. For those of you watching us from your home, from Facebook, it is always a pleasure as a community for us to get together. But what makes today's celebration even more special is today we have with us a lovely gentleman that you see is here with me on the screen of yours, Dr. Vijay Kher, the chairman nephrology Medanta Meda City, and he comes with more than 37 years of experience. And you heard him say, 5,000 transplants. He's one of those gentlemen who's seen the community evolve to where it is today. And today he's going to be sharing with us a topic that most of us have so many queries about: your TAC levels. Well, personally speaking, the only thing I know about TAC levels as a caregiver is TAC levels have to be maintained to a certain level. If it's low is a problem, if it's high is a problem. But I never got to understand what would be these problems exactly. And I'm so excited to be with you, Dr. Vijay, so that I could hear and gain much more information on knowledge on this subject. So I'm going to request you to please take over and take us through what you have in store for us.
Thank you, Marian, and good evening, ladies and gentlemen. It's a pleasure to be on this platform, and I'm very glad. I would want it more like a chat, and I would like more questions of it. But to get started, I thought it may be worthwhile sort of first initiating the talk. Let me get on to share my slides.
Yes, doctor.
Can you see the slides?
Yes, doctor, we can.
Okay, let me. Okay. Kidney transplant is the best form of treatment for patients with kidney failure and is the most cost effective. And we'll see the cost effectiveness of this treatment. And the reason why this is the best treatment for kidney failure is that if you look at the current survival and outcome data of kidney transplantation in all the good centers across the world and even in India, the 1 year survival of patients with kidney transplant goes up to about 97 to 98%. If you were to compare this to dialysis, hemodialysis or peritoneal dialysis, which is the other alternative treatments for patients who have gone to this stage of kidney failure, the 1 year survival on dialysis is about 80 to 85%. It varies from country to country, but roughly around 85%. So we lose around 15% of people in the first year itself on dialysis. Whereas in transplantation, in the very good centers now, the survival is up to about 97 to 98. And look at the 5 year survivals. Transplantation, 92 to 95%. Dialysis, 50 to 60%. And 10 year survival on transplantation is 80 to 85%. And dialysis, a large number of patients unfortunately die during 10 years on dialysis. And if you ask my personal experience of it, that I would say that how many patients do I have who have lived 10 years and beyond? I can count them actually on, not many patients. These days now, there are good dialysis, quality has improved, and the peritoneal dialysis as well as hemodialysis centers have opened up. And now you see more and more patients living longer on dialysis itself. And this is in the graphic form itself, 1 year survival, whether it is peritoneal dialysis or hemodialysis. Peritoneal dialysis is in yellow. The hemodialysis is in bluish color, and the transplantation is in red. And the first one is not 95, actually 1 year survival is about 97% and above actually. And you can see that this is the same thing that I talked about. This was in the pictures. Now, all of you, probably there are people who are mixed with kidney disease who are listening on the Facebook, but I would guess that when would you require a kidney transplant or dialysis? Usually when kidney function drops to around 10 to 15%, that means 90 to 95%, 85 to 90% of kidney function is gone, and it's an irreversible renal failure. There is no method by which we can recover kidney function. So if it's an irreversible kidney failure, which is what chronic kidney disease is, and when it progressively deteriorates, we call it end stage kidney disease or end stage renal disease. The more familiar and the better term is end stage kidney disease, because patients understand kidneys much better than the term renal, and therefore all the nephrology terminologies have been changed to now kidney, acute kidney injury, end stage kidney disease, chronic kidney disease, not chronic renal failure. All of it is kidney disease now. So that it's better understood by patients and the general community at large. So end stage kidney disease is irreversible loss of kidney function to 90 to 95%, something like that. And then that is the time when you require either dialysis or transplantation. However, if one has to consider transplantation in children or in transplantation in diabetics, one should look at this transplantation or talk about or plan about transplantation when kidney function in children is about 25% or so. We should plan, because it's much better to transplant children earlier, because growth is an important aspect that you would want children to grow to. Patients with kidney disease, especially children with kidney disease, do not grow adequately if they continue to remain in kidney failure. So it's very important to give them good kidney function with a kidney transplant and get them to grow to normal heights, because they would stop growing after age of 17 years. 15 to 18 years is the period when they will, up to which they will grow beyond that. So if you have a child at 12 years or 13 years, even if he has not reached typical end stage kidney disease, I would plan for transplant in such patients early without even dialysis. We call it, I'll come to that, preemptive transplantation, where you don't do dialysis at all, take patients straight into transplantation without even a single dialysis. So they do much better on that kind of dialysis. So in children you should be, but in general, one should plan for dialysis or transplantation when kidney function is about 20% or so that a fistula is made early, or you plan for a peritoneal dialysis, or you look at the donor who is likely donor to be, or if you want to go on a disease donor program, then you will have to be on dialysis first and then enter a register for a disease donor transplantation. But if you have a living donor, then I think we should plan for transplantation much earlier rather than later, because the outcomes are much better if you plan ahead of time rather than at the end of the time. Unfortunately, in our country, I see patients crash landing. They land at a time when they are in emergency requiring immediate dialysis, which is something which should not happen to patients with kidney disease. We should plan ahead of time. If you have patients ahead of time, unfortunately, patients are referred late in this country. There is no good referral pattern which is followed in this. Medical care is not in an organized kind of a fashion. So all these deficiencies lead to crash landing of patients with end-stage kidney disease, suddenly with an emergency, not knowing that they become suddenly very sick. They are admitted to be in the ICUs, and that makes treatment further extremely expensive. If we plan things ahead of time, we can cut down the cost of treatment. Now, when a patient reaches end-stage kidney disease, that means he has a kidney function, which we call estimated glomerular filtration rate, that reaches around 10 to 15% or so, and patient develops symptoms of uremia, which means weight loss, is not able to eat, nausea, vomiting, losing weight, breathlessness, tiredness, fatigue. At that stage, patient will require either dialysis or transplantation. And any of these therapies are complementary therapies. It does not exclude, if we put a patient on peritoneal dialysis, if at some point of time he gets a donor, then he can get a kidney transplantation. So he can move from peritoneal dialysis to a transplantation. And if the transplantation after a certain period of time fails, then he or she can go back again to either peritoneal dialysis or hemodialysis. That's what this picture shows here, that in this cycle, you can move from the hemodialysis to peritoneal dialysis to kidney transplantation. And if kidney transplantation is not successful after certain years of time, one can go back to hemodialysis or peritoneal dialysis. So one can prolong life. And in fact, people have lived with kidney failure for more than 50 years or so. And I think Vasundhara had today itself tweeted that in her book also, I think there is a patient who has lived for 50 years on kidney failure, with kidney failure, probably got a kidney transplant, failed, and went back on dialysis. And there are patients, this was in response to a tweet which Dr. Vivekanand Jha had said, that there is a patient who lived for 50 years and recently died. And his experiences about this are worthwhile. That's how he lived for 50 years with kidney failure. Now, whenever a patient reaches end-stage kidney disease, it's important for the physician and the patient to understand as to what form of therapy would be best for that patient. Now, this is decided predominantly on the outcome of the therapies. And we talked about the outcomes. I told you kidney transplantation has the best outcome, 1 year, 5 year, and 10-year survivals. Cost effectiveness, and cost is an important element, and especially in a country like India, where end-stage kidney disease care is not provided by government, not to all the patients. At the moment, it's very good now that at least dialysis and peritoneal dialysis is provided by the PM schemes for dialysis, the national dialysis scheme, at least for the poor, extremely poor people, it is available. I hope that transplantation costs of medicines, in some states they are paid for, but in many other states it is not paid for. And I do hope that at some point of time, government starts paying for maintenance cost of immunosuppressive drugs to patients who are not able to afford these drugs. And then third is the quality of life. And obviously transplantation again provides the best quality of life, is most cost-effective therapy, and outcome are better than dialysis. And obviously, whenever physicians discuss these issues with patients, it's important that the patient must be educated. Patient must be told about the outcomes of all the therapies and the alternative therapies that are available. And these choices must be understood by the patient. If there are any questions, I think they should not take a decision without fully understanding the consequences of these. And choices are always best made by patients, their relatives, and the physicians together. And I think it's extremely important for a patient who has got end-stage kidney disease to plan ahead of time, look for the consequences, the outcomes of these therapies. And that's why it's important that patients must be involved in the decision making. It's important. Doctors are knowledgeable, but patients understand their situations, their conditions, their body, everything else much better. And what else they can continue to provide easily to themselves is extremely understood. And it's very important for physicians who are taking care of end-stage kidney disease patients or kidney disease patients to understand these issues. That's where experience probably is handy. And we were talking about that with Marian earlier, that's where you feel that patients are extremely important in this decision-making process. Now, we talked about the outcome, I told you, and you can see that in this, this is a bit complicated graph, but I'll make it simpler. The straight line which says 1 is the standard dialysis survival. So if we take as a reference is the dialysis survival, those who are waiting for transplantation and they are on dialysis. And the curve which is starting from up going down below this line is the survival of patients on transplantation. Anything below the reference point is better survival, and anything above is a poorer survival. So kidney transplantation, the only time when kidney transplantation has poorer survival than dialysis is around the first 2 months of transplantation. The surgical process, perioperative process, that is the time when kidney transplantation has poorer outcomes than dialysis. After about 2 months or so, the 2 to 3 months, the use is 125 days, which is about 3 months, 3 to 4 months. That is the time when survival of transplantation becomes better. And it continues to remain much, much better than dialysis. And you can see that all in the first year itself is about 23%, 27% better, then becomes 50% better, and still continues to get better and better after that, because dialysis patients are continuously lost on dialysis. And this is one thing which I had done once for a presentation for the international community. And the cost of transplant, this is 2002, this is not appropriate today for today's cost. The cost of hemodialysis and CVPD was about 4.5 lakhs per year. Cost of transplantation at that point of time was also about 4.4 lakhs. The second year cost of immunosuppression of drugs is obviously about 1 lakh of rupees, but cost of dialysis, peritoneal dialysis continues. So in about 2 to 3 years time, you can see that actually cost of transplantation is much more effective, cost effective than dialysis or transplantation. So transplantation has better outcomes. We talked about that. And long-term outcomes. And we also now look at the data on that it's a much more cost-effective treatment. Relatively, patients have to spend, if they have to spend from their pocket, obviously they spend less money on transplantation than on, and there are a lot of studies which have looked at quality of life. Quality of life obviously is much, much better on transplantation. A successful transplantation, obviously patients have to do well. There are adverse effects of drugs, which we will talk about, and we are talking of adverse effects of the drugs and there. So, but considering everything else, transplantation provides a better quality of life. Now, what are the kinds of transplantation? And many of you may already be aware, disease donor transplantation, which is taking donors from the brain dead who die either from strokes or from accidents, and patients are brain dead and their heart is still beating, and the kith or they themselves have wanted that their organs at the time of brain death should be donated, and then the family also agrees to that donation. And these days with these disease donation, you don't do only kidney transplantation, you can do liver transplantation and lung transplantation, heart transplantation, and many other organ transplants which can happen. And therefore that kind of program is extremely important for treating end stage organ failures. And I think for a country like ours, it's not yet developed to the extent that it should be, but I'm glad that it's, especially in certain states, especially southern states and western states, has started picking up. Northern, unfortunately, the northern belt is not as good as, I can't say with that pride, and I am ashamed of myself and the North Indians actually, that we are not on the high level or in the front lines of disease donor program. But I do hope that as awareness about this increases, and Kidney Warriors is really playing a big role in making awareness about disease donor. But all of us need to get involved into sort of making greater and greater inroads into making this a very popular option of kidney, so that the need for living donation goes down, or at least there is a mixture of fairly high amount of diseased kidney or organ donation programs, and living donor programs add on to those kind of transplants. In a living donor transplant, the donor can be either a family member. Once in a while, it could be a distant family member, it could be a close family member, and it could be also unrelated donors. In the Western world, unrelated donors are accepted. Somebody who wants to donate a kidney to someone who he doesn't know also can donate a kidney in the outside. In India, it's not as very common because commerce had been involved into organ transplantation in a bigger way in our country, and therefore the laws and the also the social strata as it exists, there is still a lot of poorer people in our country, and there is a possibility of exploitation of that group of people, and therefore there are stricter laws about it, and that is a disincentive for an unrelated kidney transplantation, or somebody just volunteering to donate a kidney to someone. In other countries is a possibility, but unfortunately in our country, because of the commerce getting involved and some form of exploitation which has got involved into the transplantation, or had been involved. At the moment, I don't think there is as prevalent now. And I was talking about the preemptive transplantation, and that's the transplantation where you do not take a patient into dialysis at all, and you can go ahead straight from stage 4-5 kidney disease to straight to transplantation. But it needs planning ahead of time. When kidney function is 20% or so, we plan ahead of time. We look at the donor, find the donor, investigate the donor. We are ready for transplant. And the moment patient becomes symptomatic, we go ahead and do a transplantation quickly and without dialysis. And this has been, we are one of the highest performers of preemptive transplantation. 20% of our kidney transplants over the last 15-20 years has been preemptive transplantation. And this is the transplantation where 1 year survival is 99% in our program. But it requires definitely a very good outcome of the transplant program, because you are taking a patient who hasn't suffered the sufferings of dialysis at all. So he is relatively asymptomatic. And if anything happens to this person on transplant, then he or she is going to feel that they haven't looked at a comparative dialysis outcomes or dialysis sort of what are the kind of experiences each patient faces on dialysis. So this is relatively asymptomatic patients. So they should do extremely well. So the program has to be extremely good, and the outcomes have to be good before you suggest preemptive transplantation. Fortunately, these days now, previously it was that only ABO compatible transplants were done, which was that O is a universal donor and O could give to anybody. AB is a universal recipient. AB can take from any blood group, but otherwise A and B blood groups would get either from O or from A or B, their respective donors. You could not cross the ABO blood group barriers. However, although in Japan and other countries it was being done for about 35 years now. But in our country, over the last decade or so, ABO incompatible transplant has picked up, and all across the country now, this has increased the pool of donors which is available now. So because of ABO incompatibility, previously donors were rejected, but now we can go and do this better, and the outcomes of these are also being fairly good. And so you have a widening of the donor pool now. So you can have ABO incompatible donors, and you can also do paired kidney donation. So somebody has an A and he requires B, and there is another pair who has B donor and requires A. So you can exchange the donors of one giving to the other to make it a blood compatible transplantation, because that sort of removes this minor risk of ABO incompatible transplantation. So you can do a paired kidney donation. And in fact, a lot of transplant units have started doing that. I do hope that we also have a national registry of paired kidney donation. I think we should develop that, or if not national, at least regional. In Delhi, many centers can look at pairs which don't have compatible donors. Somebody requiring B has an A donor, and then they can exchange, and we can create paired kidney donations across the regions and all that. That improves the outcomes of transplantation. Age is usually not a bar for transplantation. Normally, in India, the average age of survival at the moment is about 68, 69 years of age. So many times patients in the age group of 60 and above are given advice that they should not go for transplantation. But I don't personally, I don't think it's not the chronological age which matters. What matters is the biological age of the person. And biological age of the person, I mean, is you look at what is this status of other organs in that person. In a relatively older patient, what is the status of the heart? What is the status of the brain? What is the status of the liver? If all these organs are good, a 80-year-old, chronologically 80-year-old person could be a biological 60-year-old person, whereas a 45 or 50-year-old chronologically aged person could be equivalent to an 80-year-old person from biological point of view, depending on what comorbidities the person has. And we have, in fact, I have personally transplanted people up to age of 79 years. And obviously, we have taken donors about the age of 75 and 80 years also. Some, not many, but we've looked at them very, very carefully. And if they've been found to be good, we have taken such donors. And I'm sure all people, Sundar, who talked maybe last week or last 2 weeks back, I'm sure he would have also had many such patients in whom we have taken older donors as well as transplanted relatively older recipients as well. So I don't consider a fixed age as a contraindication for transplantation. It depends on so many factors, but obviously you have to take into consideration a 65-year-old man or a 80-year-old man after transplantation is not going to become 35 years. That's important to understand, that he will still remain 85, except that his quality of life and may become better than being on dialysis. Some of the contraindications for transplantation are predominantly active malignancy or active infection. I think these are, or if there is a cancer or something which the expectation of life itself is extremely low, then there is no need to do a transplantation. Or somebody has very severe lung disease, very severe heart disease, which cannot be taken care of, or has strokes, and his overall physical health is not very good, then there is no reason why we should provide a kidney transplantation to such. Mental retardation, severe mental retardation. But I think psychological disorders and all are not, they are relative contraindication. If these can be taken care of by medications, then I think we can transplant. And I'm sure in India we have severe psychiatric disorders. We've had patients whom we have transplanted after correcting those psychological disorders. And family in India provides a lot of strength to some of these patients. And I have had a patient who did extremely well with severe psychiatric disorder and did extremely well. Her brother-in-law donated a kidney to her, and she lived for good, I think, 15, 16 years and did extremely well. So I think I can show you these, that transplantation can be an extremely satisfying kind of procedure for many people. And this is a young lady. I have the permission of some of these ladies who to show them here. And she was married and then had a child after the kidney transplantation. This is her child, which she bore after kidney transplantation. And there's another one. And the lady in the center is the one who received kidney transplantation. Mother donated the kidney to her, and she, after marriage, had two kids. So it's possible to get married after transplantation, or if you are married and then have children after transplantation. And this is another. And this is another. Many of these young ladies actually have formed a group together. They go for lunch and dinner. They don't invite me anytime, but they send me these nice photographs that they take after they have had their lunch. And this is another girl who had a transplant, I think about 15, 16 years back, and had a second pregnancy. This is the second one. And this is her daughter, who appeared in class 12 last year. And she had come to meet me, and you can see that this is her first daughter. So you can have a fairly good, successful transplantation, leads to a very, very exciting and a fruitful life itself. And as a physician, you feel extremely good in providing that kind of quality of life as well as a successful. So nothing, a successful pregnancy provides the best kind of an outcome and happiness to that person and to the family. I will stop here and I'll be more than happy to take questions on care, post-transplant care, which I would want to be done on a form of a chat. You can have questions and answer, then I can answer them. Thank you very much. I I can't hear you.
Yes, Doc. It's perfect.
Yes.
I can see you better. Thank you very much for taking us through that presentation. And yes, we've got a lot of questions that's coming. And in no particular order, I'm just going to go one question after the other.
Yes.
The first question that comes to you is, will there be a difference if you take your TAC tablets on an empty stomach or if you take it with after taking food? Will there be a difference in your levels?
There is an increase in the TAC levels, but it doesn't matter actually as far as tacrolimus interaction with food is much less in comparison to cyclosporine, which was the previous drug which was being used, but now almost 95 to 99% of patients are on tacrolimus. There are few patients who are on cyclosporine, and with tacrolimus, the interaction is much less. What we usually tell people is that take it always the same way. If you want to take it empty stomach, that's fine. If you want to take it after food, that's also fine. But when you do the levels, always do the levels the same way, because levels might slightly alter if you are taking it empty stomach or you're taking with food. So our usual suggestion to people is overall levels, it doesn't matter. The area under the curve for 24 hours for the drug, which is more important than a particular level, doesn't matter whether you're taking it with food or you're not taking it with food. So ultimately it doesn't matter. But I agree that if one day you're doing levels, taking it empty stomach, then next day you're taking it with food, then day you're taking it 1 hour after the food, don't do those kind of variations. It's always good to take it the same way, with food or without food.
Is there TAC injections available, Doc?
In other countries they are, unfortunately in our country not, but I think there is an attempt being made to have TAC levels, TAC injections also available, and these become important especially when person is going for surgery, and especially abdominal surgery where intake of these drugs becomes a bit of a problem, and therefore injectables become important in that point of time. And I think there is one company which is about to market injectable forms of tacrolimus.
Then can tacrolimus cause diabetic? Can get diabetes with tacrolimus? And the add on to the question is, what could be the other side effects of the drug?
Yes, the tacrolimus and cyclosporin, these are called calcineurin inhibitors because the way they act in the body is by inhibiting calcineurin, which is the enzyme which is important for immunosuppression and all that. So that's where it suppresses that calcium. So it's an inhibitor of calcium. So both calcineurin inhibitors can cause diabetes, but tacrolimus is more diabetogenic than cyclosporin. But it doesn't mean that we should not use these drugs, tacrolimus, in a diabetic patient. No, I think it's good to use this drug in a diabetic as well as in a non-diabetic patient and control the diabetes effectively. The purpose of giving tacrolimus or cyclosporin is to produce immunosuppression so that the organ for which you are taking this after the transplantation is preserved. The body does not launch an rejection episode against that organ. In case of kidney, it will be kidney transplant. And so in a kidney transplant, the kidney which has been put into this recipient, the body keeps on saying that this kidney is not mine. Therefore, body considers it as a foreign. It is extremely important for this kidney to survive in this abnormal environment. The body is not innocuous in our environment. The body always says this difference of self and non-self is very inherent in all of us. And this is an extremely important element in our survival. That's how we survive the viruses, the bacterial infections, the cancers and all. Otherwise, we have so many things which are getting into our body, either by eating, by drinking, by inhaling in through our skin and all that, sun, everything else. So all of these are external things by which we could not survive. We could have been killed by viral infections, cancers and all. But we survive because we can differentiate self and non-self. And against non-self, we have these either antibodies, or we have various kinds of missiles which we form, which prevents us from these bacterial infections and all. So this is an instinct which is present in everybody and everybody. And these drugs are important to prevent this attack on this new organ which has been given to this person. So therefore, it's important to give that. And tacrolimus is definitely a better drug than cyclosporine, more potent. And it has different kind of side effects, but different than cyclosporine. Cyclosporine, especially ladies don't like cyclosporine, but it causes hirsutism. So you get hair across at places where women don't want it. Even men get a lot of hair. Then gingival hypertrophy, the gums become extremely broad, they become injurious, they become soft. And so gingival hypertrophy occurs, so teeth fall off after cyclosporine. With tacrolimus, that is much less. So with tacrolimus, people can become bald, more common. But all these side effects don't occur in everybody. And once you are on the dosages are lowered as the transplantation goes on for some period of time. We will come, maybe I will discuss that tacrolimus levels have to be maintained at particular, and this varies at the time of transplantation and what duration after the transplantation. And so there is an initial phase of transplantation when tacrolimus levels are high, and then there is a maintenance phase of immunosuppression. When you go after 6 months or so, the tacrolimus levels have to be lowered. And then the adverse effects of these drugs also go down. So the other adverse effects of tacrolimus, in addition to diabetes, that both cyclosporine as well as tacrolimus can cause kidney damage. And that's why we were talking before we started this program, we were talking that too much of high levels of tacrolimus are not good because that can cause kidney damage, and too low levels can lead to rejection. And therefore you may have organ dysfunction because of rejection. So it's important that we keep the levels at an appropriate for that time period of the transplantation so that you do not get those adverse effects. In addition, tacrolimus can cause liver toxicity, tacrolimus can cause neurotoxicity, the toxicity of the brain and other things, but those are rare. The commonest ones are usually the kidney toxicity, diabetes, and if their levels are low, then acute rejection. So these are the common ones.
So when you spoke about toxicity, I have a question. Actually, my next question was based on that. We have a case study of a patient who's written and mentioned, what are the alternative options available for people with TAC toxicity? Biopsies proven TNI toxicity. What steps should they take to avoid antibody-mediated rejection? That's the question for you.
Yeah, I think it's become very important from the studies over the last decade or so. People have tried to remove calcineurin inhibitors, both cyclosporine and tacrolimus, trying to see whether we can remove these drugs from patients and give alternative drugs, because they have, especially in people who have adverse effects related to TAC toxicity, like this case study that you talked about, that this is a patient who's probably had high TAC levels and has TAC toxicity. Sometimes somebody may have TAC toxicity on the biopsy, but the TAC levels may not appear to be very high. So it's at the level of the organ that there is a toxicity which is likely. And in these patients, actually, you might think of altering or changing these drugs. There are other immunosuppressive drugs which are available. One is Advagraph, the Advacan, which is a drug called mTOR inhibitors, sirolimus and everolimus. These are drugs which are available. So one can use these drugs. Sometimes you use this along with either cyclosporin or tacrolimus also, and decrease the dosages of the tacrolimus to almost 50%. So you will decrease tacrolimus to 50%, use smaller doses of everolimus or sirolimus. Now more frequently is everolimus, because now tacrolimus and everolimus, and you can combine these drugs and that can be used. Those are the other alternatives, in addition to the other drugs, mycophenolate mofetil and prednisolone or visolone or steroids that are given in patients with trans. Usually you take about 3 drugs to maintain the usual kind of immunosuppression in patients to prevent from acute rejections. I was talking about that people have tried, certain studies were done where you try to remove the calcineurin inhibitors after maybe 3 months, 1 year or so. But unfortunately, that has led to higher chances of acute rejection. So at this point of time, personally, I also feel, and most of the world also agrees with that kind of a feeling, that calcineurin inhibitors need to be maintained. We can reduce the levels, we can reduce the dosages, but we should try to keep tacrolimus, because it seems to be the most important drug for survival of an organ in the body for longer periods of time without any harm to it. So that is the bottom line. So by and large, if one has to pick one drug which should be given, it should be a calcineurin inhibitor. Whichever that calcineurin inhibitor is, somebody doesn't tolerate tacrolimus, then we can give cyclosporin. But if somebody, most of the people don't do that well with cyclosporin, then I would use tacrolimus in this patient. One of these 2 drugs should be given to patients with transplant all along.
Doc, you in the previous question you mentioned about the stages of post-transplant, the first 6 months, the first 1 year, the first 5 years. So give us a little more information in terms of how would you look at a patient's post-transplant in terms of maintaining the appropriate TAC levels. So for 6 months is it something, 1 year, and give us 5 years, and then post 5 years.
Yeah. So when you start at the time of doing the transplantation, usually, which is called an induction phase of transplantation, and which usually is first 3 months of transplant. So what you do is that since the transplant, you put a new organ into the person, especially, say we talk of kidney transplant here much more. So when you put a new kidney in the person, so you start immunosuppression about 1 to 2 days before in a living donor transplantation. So we start tacrolimus, mycophenolate mofetil, about 2 days, usually 2 days before, 1 to 2 days before doing the transplantation. So that by the time the transplantation is done, the person has achieved adequate levels of tacrolimus in the body. As I said, that tacrolimus seems to be the most important immunosuppressive drug, which is important for sustenance of this organ. And the usual levels, which we try to keep for first month itself, is about 8 to 12 nanograms per ml of tacrolimus. And for cyclosporin, around C0 of around 150 to 250 nanograms per ml. And if we consider C2, which is doing 2 hours after the morning dose of cyclosporin, that level has to be something like 800 to 1200 to 1400 to start with for first month or so. And then second month, you would want it to be something like 8 to 10 nanograms of tacrolimus. And when you go up to, so second and third month would be around 8 to 10 nanograms. And then third month to 6 months is usually 6 to 8 nanograms. And then after 6 months is usually the maintenance phase. We usually want the TAC levels between 4 and 6 nanograms, usually around 5 and above. And all along the life of an organ transplant, especially the kidney transplantation, the tacrolimus level should be around 5 or so, by and large. So, and the most levels maintained across the world are between 3 to 7 nanograms per ml. So I would say around 4.5, 5 nanograms in about 6 months old transplant would be a reasonable level. And it should not be a particular level. See, when you are looking at these numbers, there is a variability in doing tacrolimus levels. So in the same patient with the same dose, so a particular patient is taking the same dose and he does levels, say at 6 months, then at 8 months, and we haven't changed the dose. But you will find that the TAC levels may be up and down actually. So sometimes it's surprising actually. So there is an inter-patient variability. The same dose of drug taken by different people provides different levels because the metabolism of this drug is different in different people. So people exchange notes when they are sitting in the OPD. How much of tacrolimus are you taking? He says, no, I'm taking 4 milligrams and my levels are this. And the other guy says, I'm taking 0.5 milligram twice. And now the guy who's taking 4 milligrams twice is spending money for 8 milligrams of tacrolimus. And the other guy is taking 1 milligram. They are at the same duration of transplant. But this is body's different pharmacokinetics and the pharmacodynamics of the body, the genetic variations that occur in all of us, and how we metabolize drugs and therefore produce different levels of these drugs. So every person has to be monitored much more carefully, and one must know what is the kind of levels a particular patient is important. One should not change if especially there is variation in the same person with the same dose. It should be the trend of levels rather than one single level which needs to be. Many times patients get so worried that the level comes so different. And I usually look at how has been the levels over the past 6 months or so with the kind of dosages that the patient has been on. That's more important rather than a particular level that that person has. So it's important. And I think patients many times might be sort of tempted that they might change the dosages based on the experience that the doctor may have done previously, and they might do it on their own. My suggestion to them would be do not delve into this. This is more difficult, much more difficult. I can tell you that going across and handling a patient post-transplant is the most difficult and slippery road on which a physician has to travel. And it is long experience that tells you as to how you should navigate that area. So it's a difficult area. Do not delve into this on your own, and do it with a physician, do it with the transplant physician. And I'm sure the transplant physician over a period of time become accustomed to seeing a particular patient, and they may not have the same formula for different patients. Different patients may be managed a bit differently because everyone is different. And it's important for people to realize that. And I think that's important.
Thank you, Doc. Our next question for you is, the TAC levels maintained, would it be different for a cadaver transplant patient and a live transplant patient?
In the initial phase, actually, for cadaver transplantation, we tend to give other drugs and give an induction because these patients may have graft dysfunction for first 2-3 weeks, because this kidney is, especially if it has traveled from one area to another area, there is a lag period of transplantation. It may be in the cold ischemia, maybe 8 hours, 10 hours. And then therefore the kidney may not immediately function. See, living kidney functions immediately, almost invariably. Whereas the diseased kidney may not function immediately. So in those days, for them to recover their kidney function quickly, we sometimes keep TAC levels for those initial period lower till it recovers kidney function, and then bring them back to the same levels as 8 to 12 nanograms. But if the kidney is functioning well, then you get it to 8 to 12 nanograms. That's why induction with injections of either IL-2 receptor antagonist or with a thymoglobulin is done in cadaver transplantation almost invariably. But in living donation, it depends on how much is the HLA incompatibility. If there is an HLA incompatibility, then you give an induction. And if it's a higher risk transplantation, then you give an induction. Otherwise, in a low risk living donor transplantation, you may not give an induction of injections of IL-2 or thymoglobulin. And then get to TAC levels immediately. So induction provides that window in which you can build TAC levels in a diseased donor transplantation, which may not function immediately.
Doc, this is a question that I always wanted to know. What is the ideal way to test your TAC levels? Okay, I'm just going to give you an example of what has happened in a case study that I know. So the person takes their tablets 9 o'clock in the night and again 9 o'clock in the morning. So what would be the best time to go and check? Because once they checked it at 7 o'clock and obviously the results were different. And then they checked it at 8:45 and then the results were different. And then
Yes.
obviously doctors had altered it based on that. But we never informed, this is actually my case.
Yeah.
We never informed the doc that we do the test
Yeah.
earlier. So can you
No,
give
no,
us?
it's important that it should be 12 hours after the previous dose.
Okay.
So, and the reason why it is important is that you want to take the trough level actually. And when you take the drug has a peak level, which is within usually 1 to 2 hours of its intake. So it achieves a peak level and then the metabolism of the drug occurs. And the trough level is the one which we measure usually in tacrolimus. So it should be 12 hours after the previous dose and before you take the morning dose.
Okay.
Now, many times people start taking these drugs at 6 o'clock in the morning, 7 o'clock in the morning, 8 o'clock in the morning, 9 o'clock, 10 o'clock. Now, if you are taking these drugs at 6 o'clock, at 7 o'clock, now what happens is there are no labs which are open at 6 and 7 o'clock. So that's the problem. And then many people, you may not be able to call somebody at 6 o'clock to collect the sample. There's no lab open at 6 o'clock. So you may not be able to give the sample at that. So many times I usually tell patients not to use these drugs at a time frame when it's not going to be easy to monitor these. So start taking them at about 9 o'clock, 9 o'clock. That your labs are open. But even if somebody is taking at 6 o'clock in the morning and 6 o'clock in the evening, either they can do a 6 o'clock evening level, although with tacrolimus, I would say that morning levels are the best ones to do. But sometimes you may have a lab which might be able to do the level 6 o'clock in the afternoon, in the evening itself, and then do the evening level itself. Or on the day when you are going to do the level, I would say take the drug at about 9 o'clock or 8 o'clock when you have the next is 12 hours after that. Because next day you're going to give the test. The lab is going to be open at about 8 o'clock and afterwards. So plan it in such a fashion that it is taken about 12 hours before you get the sample. And you should give 15 minutes before or 15 minutes after. So if you have taken the drug at 9 o'clock, the sample can be given between 8:45 to 9:40, 15. So give about half an hour, 15 minutes here or there will not make that much of a difference. But yes, 2 hours or 3 hours before or after is going to make a huge difference in the level, the type of level. So that's important. Many times, actually, in transplantation, you learn also to do things that, see, there are patients who are traveling and they want to come to the center. They want to give the sample at Medanta. Now, the train gets delayed. And it's quite possible that the train is delayed. They cannot give them. They have made the return journey in the evening. Now, obviously, they have missed the bus. So what we tell them is, on the day they are coming to visit the center, they should take the drug maybe later, 11 o'clock. So that they give a margin of about half an hour, 45 minutes, 1 hour. If they reach 15 minutes, half an hour or 1 hour early, they can wait and still give the level. It's important to give the level because they're coming from far off places. So it's important that these considerations are kept in mind. It is important to keep this 12 hours important between the last drug intake, and the sample.
Doc, you made a very interesting point that I'd like to ask you another question based on. So you mentioned that if your TAC levels are taken 6 in the evening and 6 in the morning, and the day you want to do your test, you could plan your drugs around the 9 o'clock time. So that brings me to a question that normally all of us are advised with our doctor to keep our TAC levels on an alarm. So we take it exactly at that point of time. So my question is, I'm sure you're going to advise everybody to please stick to that timing that you're meant to take it. But in case for whatever reason, there's a delay in us taking our TAC levels, our TAC tablets, what is an agreeable delay that you will go with? Or if you've forgotten to take it, is it something that we have to be very concerned and call our doctors about? Can you give us an insight on that, please?
Yeah, no, I think it's important. We tell all our patients that they should not miss their immunosuppressive drugs, and they must try to follow a clock. And that's important for the purpose that you do not miss it. And patients should be reminded by a clock that you need to take this drug at a particular time. That's important. But obviously, this is a lifelong medication, so there will be events in the life of a person that at certain points of time they might miss, or they may have forgotten, or they don't remember that they have taken the drug or not taken the drug. They've already gone to the office. So we tell people that they must keep an extra packet in their purses, in their at office, at places, different places as well, so that the moment they remember, they should take these drugs. They should, if you remember 2 hours later, you should remember, take it back, and make a habit not to forget it again and again and then. It shouldn't be a habit every day, but once in a while, if you sort of take these drugs like for practical purposes, that you want a drug level to be measured, which is important, extremely important. So you may take it knowingly that you delayed by about 2 to 3 hours and say, okay, that this is okay. But if you are at a place that you do not have a drug, then or sometimes you run out of the drug, and somehow, although we tell our patients that they must keep their stocks 2 weeks of stocks, and when they are about 2 weeks, they should order the next one. So this is important, so that your stocks are always there, and you don't run out of these drugs. But you are at a place, or you travel to some place, and I've had these experiences, people calling me all of a sudden that they were traveling to US and they kept it in the baggage, and the baggage never reached, and now they have no drug available to them. So you have to make these drugs available. But if at any point of time you do not have drugs, then something which you can get, sometimes you don't get tacrolimus and mycophenolate mofetil from the drug stores, where you may be at a place in a safari somewhere, or wherever you may have gone, in a resort which is far away from the city. But prednisolone or steroids, increase the dosage to, if you are taking 5 milligrams, go to 10, 20, 30 milligrams for that day itself. That's a drug which is easily available at most places, is an emergency drug. So you should be able to get that. But this should be one kind of an event like this, and 2 to 3 hours of delay for getting a drug level may be okay.
And like you mentioned, what if you've forgotten whether you've taken your drug or not, and then you take it the second time?
That's okay. You should. I would err on the side of taking an extra drug on that day rather than missing the drug.
So you would advise
that will be a better mistake than not taking the drug at all.
Doc, we have a warrior who's mentioned to us that doctors keep changing his TAC levels, because when the dosage of his TAC levels are increased, it goes extremely high, and when it's reduced, it goes extremely low. So he's wondering what is the right thing to do, and what
I wouldn't. This is what I said, that I would rather look at the trend, and this is a problem that I think in India the drug levels are done too frequently. Sometimes these drug levels are provided free by the
For the
the
company.
drug companies. And since it's available free, so every patient feels that it's good to do it. But sometimes doing it too frequently creates problem because there is an inherent variability in the drug levels in the test itself. So you add errors, and the doctors will be tempted to change.
Huh.
And it's like playing ping pong. You have a ball, you change the dose, it goes up. Now you change the dose again, it goes down, up. So I would not do this. In fact, in the initial first 3 months, you must do the levels maybe once in, initially for 1 month, you may be doing the levels at least 4 to 5 times in a month. Second month, I will do it at least twice in a month. That would be the general kind of thing. In a particular patient, you might have to do it more often in third month. But after 6 months, I would get the levels done unless I have changed the dose, well, once in 3 months or so. And after about 2 years or so, I'll get it maybe once or twice in a year and not do it every time. But unfortunately, what is happening, and you raised a very important point, and I think this, I see it every day, that people come with these levels. I told them I didn't ask you to get it done. No, sir, wo kara rahe the, wo to, I said, no, it doesn't help me, because then he forces me to say, sir, ye to bahut kam ho gaya. And then I also get worried that is it really so low or not? And usually there are errors in these. And I think one should not do it too frequently. One should use your common sense to see and it should be the trend. Don't allow your physicians to tamper with dosages too frequently. I do hope that physicians also don't get tempted to change because patients force them to do these kind of things. And I hope they don't do this. The general, I wouldn't be able to give a correct answer to your query as such, but it's an important question, and I will answer it not necessarily in relation to your case as what should be done or not, but a good physician and a good transplant physician who knows the patient well, understands it better as to what is the kind of a transplant that is. And that's why I said that it is a kind of patient. A shrewd, good, astute clinician should be able to decide whether a particular level is good for you or bad for you. And that's why I said that every patient should not necessarily try to do what the other patients are trying to do on their own. And I think it's important that you discuss it with your physician, and he or she would be probably in the best kind, especially since you're raised that there is a concern that this is a low level and all that. So he should be sort of responding to this question if it really hits in his head as well, that yes, she's raising an important, maybe I should. He looked at it again and he felt that probably, although it was still on the lower side, but he felt that probably your overall levels have been good. You've done extremely well, and he knows you so well. So I think a good physician might be able to handle it reasonably well without changing too much of dosages based on just levels itself. But a general kind of a pattern for most patients, if you look at the studies, is that usually the levels should be around 3 to 7, as I said, 4 to 6, maybe a smaller margin. 3 to 7 is a larger margin kind of a thing for different patients. So 2.6, 2.8 may be a reasonable. The other thing is, one also has to know where the level is being done, whether it is being done in the same lab, or because what is happening when these drug levels are being provided by drug companies, they enter into different kind of contracts with various providers of drug levels, the labs, and labs vary in their methodology itself. So TAC levels may be done by a mass spectrometry, which is perhaps the best method, but then it's like a B-52 bomber. The machine is very good, but we need to have a good pilot to run it. Unfortunately, many labs have spectrometers, but the persons who are doing the spectrometry are not trained. So the levels may be extremely variable. There may be another one which is done by architect, which is chemiluminescence test. So it's important to know as to where those levels are also being done. And I think your physicians would know it much better as to which labs they should be looking at. Sometimes it's important to tell a particular person as to that these are the good labs. And we did a study sometime back, and with this an Indian study where we looked at 4 or 5 labs, because TAC levels were being so variable between labs, and we found that actually only 2 labs turned out to be good, all other labs were bad. And actually, so it's important also to know where is one getting the lab test done, and then one should continue to get the lab test done by the same lab every time, rather than changing labs. One time one lab that didn't turn out to be good, you keep on testing every lab in the country. That's also not a good way of doing it. So my suggestion, I agree with your physician that I think the temptation to be based on levels, go by the trend, go by the patient. What kind of patient are you talking about is a better kind of a method of monitoring these patients, rather than doing it just by the book kind of, or going by the level itself.
Thank you. Chandralekha, I hope you got your answer.
Yeah, thank you. Thank you so much, Doctor.
Yes.
Move on to the last and final question, Doc. And this I've got just now from Facebook. Your question is, Doc, I have undergone a preemptive kidney transplant 16 years back. Suffer from liver disease as well since 7 years. My creatinine has been ranging from 2 to 2.6. Since the last 7 years post dengue infection, my TAC levels have been 3.5 to 3.9. Since years with a dose of my tacro of 1.5 BD and 5 mg steroids. No other immunosuppressant drugs due to the drug-induced low WBC. I wish to know how to reduce and maintain my creatinine levels.
No, the creatinine levels, I don't know whether the biopsy was done to find out whether there is some damage to the kidneys and what kind of damage it is to the kidney. It is always good to find out. The levels are actually, the levels that he's talked about are reasonably good. Patients with liver disease usually have high TAC levels because the metabolism decreases in patients with liver disease. So they require smaller dosages to produce the same levels as such. But his drug levels look to be okay. 3.9 seems to be okay. At least one doesn't expect too much of toxicity related to TAC in the kidneys. But it would be better that if there is somebody who has got kidney dysfunction and one doesn't know what is the kidney dysfunction due to, it would be always good to have done a biopsy. I'm sure he would have had a biopsy done, and that would tell you as to what is the reason for kidney dysfunction. If the kidney dysfunction is treatable, if it is TAC toxicity, then one can reduce the TAC levels, use another immunosuppressive drug if one has to remove tacrolimus, or reduce the dosages of tacrolimus, add, as I said, everolimus or other things like that. Or if it is because of rejection or any other drug toxicity or anything else, then one needs to treat it accordingly. So you need to find out what is the cause of kidney dysfunction. Creatinine is not only altered by the TAC levels. Creatinine can also be altered by other dysfunctions like acute rejection or a new kidney disease, recurrence of the same disease which caused the kidney failure for the first time. So you can have that kind of disease also. So one needs to find it out.
Well, thank you very much, Dr. Vijay Kher, for your time and so patiently and so beautifully answering all the questions that our community has put across to you. And the one takeaway that I've definitely learned from you is just because the tacrolimus test is available free of cost, don't keep checking it constantly.
Yes.
And it's difficult for the physician to understand. Stick to the same timing of your medications. Take your test 15 minutes, maximum 30 minutes to maintain that 12 hours gap. If you're a person who's taking your TAC on an empty stomach, continue taking it that way. If you take it with food, continue taking it that way. So I think these were important things that we need to know. And once again, on behalf of the community, I would say it was a privilege chatting with you and getting so much of information that is so important in our lives. On behalf of the entire community, I take the opportunity to say a big thank you from the bottom of our hearts, Doctor, for joining us.
Thank you, Marian, and it was a pleasure being on this forum.